Hi, welcome back to the lecture series. My name is Fong Yee Liu and I'm an F1 in Queen Elizabeth Hospital. I worked in acute medicine, geriatrics, and now I'm on respiratory. Today I'm going to talk about the role of F1 in COVID. This lecture is part of a series that will be uploaded once a week until August. The first 6 will be on COVID, the next 4 on the role of F1 in different shifts, and the last 2 on SJT. So one important role of F1 is recognizing COVID. So that could be in clerking in A&E or in the ward. So in the ward, recognizing COVID patients is very important because they could have acquired COVID in the hospital but in a non-COVID area. So recognizing them early can help with infection control and stopping the spread of disease. In clerking, there's various things that you need to look for. A lot of these are described in more details in the previous lecture diagnosing COVID, but I'll also talk about the main points here. So in terms of risk factors of poor prognosis with patients with COVID are shown in the table here on the right hand side. So odd ratio of more than 1 means that the factor is a risk factor. So basically old age, being a male, smoker are at increased risk of poor prognosis, and all these chronic diseases also increase the risk. The most common symptoms that you'll be looking for are fever, new persistent cough, anosmia and ageusia. There's also a lot of other symptoms that's commonly reported in COVID that includes myalgia, fatigue, GI symptoms and a lot more. In terms of ill contacts, it's useful to ask because a lot of them would mention, oh right, I think I had a friend or a relative at home who had a bit of a cough and sore throat, but they recovered from it. And that raised the suspicion of COVID. You, in your clerking, most likely need to distinguish whether this patient should be green, which means definitely not COVID, amber, maybe possibly COVID, and red, which are for patients who are definitely COVID. That helps with infection control. In blood tests, you'll be looking for lymphopenia, raised CRP, raised D-dimer, and raised TROP. These are classic for COVID. Not everyone needs an ABG, but if they're requiring oxygen, they're quite short of breath, or they just look unwell in general, then definitely do an ABG because that will show how unwell the patient is and that will affect the management plan. So what you look for in an ABG is whether they're acidotic, whether the PCO2 is raised, are they hypoxic, and if they have a raised lactate, then it could indicate a very severe COVID, which if they are already on high flow oxygen, you will need a senior review and an ITU review for possibly intubation and ventilation. Chest X-ray is a great diagnostic tool for COVID. Here on the right hand side shows a classic chest X-ray of a COVID patient. So that's bilateral infiltrates, that's typically peripheral and basal. Some people might have CT scans as well, but not all of them. Usually when the D-dimer is more than 10,000 and they are short of breath and tachycardic and maybe desaturation as well, then you might consider a CTPA to rule out PE. All patients now who comes into the hospital as an inpatient will require a swab, our job is to make sure that the swab is done, and because that will help with discharge planning and also allocation in the ward. In terms of treatment, typically you would start them on the antibiotics because of the raised inflammatory markers. So depending on the local microbial guidelines, you would start them on antibiotics that cover for a CAP or a HAP, or if you're also thinking about sepsis from urine or abdominal source, then prescribe the antibiotics according to that. You can consider starting dexamethasone if the patient is unwell with COVID, because it's proven to improve the prognosis in the recovery trial. So if they started requiring oxygen, then you can start dexamethasone given that there's no contraindications. Fluids is one thing that you need to be careful for. Assess the fluid status. A lot of them are dehydrated and AKI. In that case, prescribe the fluids. But if they're overloaded and if they're already in ARDS, then you need to be very cautious about fluids and most likely don't give it. Document oxygen target saturations very carefully, because most COVID patients in the hospital will require oxygen, and typically the target sats will be more than 94%, but if they're at risk of CO2 retention, then target sats should be 88 to 92, so that the patients who have COPD or have chronic lung diseases. Documenting it clearly will help the nursing staff titrate the oxygen, and that prevents over-oxygenating these chronic or acute CO2 retainers and putting them into type 2 respiratory failure. I've put hyponatremia here. It's not proven to be related to COVID, but since COVID started, we have observed more patients coming in with severe hyponatremia. So the reason I want to go through it is because it's increasing in prevalence, and you have to be very cautious with the management of hyponatremia because it can lead to serious complications. We had a patient in his 50s whose fully independent background of hypertension came in with a sodium of 96. He started with a GCS of 14 out of 15, and after management he started having seizures, and since then his GCS has been between 8 and 10, so leaving him with severe comorbidity due to a complication of hyponatremia. So hyponatremia is defined as serum sodium concentration of less than 135 millimoles per liter. It can be classified into mild, moderate and severe biochemically, or depending on the symptoms. So if it's less than 120, it's severe. If it's less than 128, it's moderate, and if it's less than 135, it's mild. And in terms of symptoms, mild hyponatremia can be asymptomatic. You can have cramps, subtle behavioral changes, or attention deficits. In moderate hyponatremia, you could have gait disturbance, frequent falls, confusion, lethargy, headache, or loss of appetites. In severe hyponatremia, you could be vomiting, having spasms, seizures, loss of consciousness, or even respiratory arrest. So if they have a low sodium, you would need to assess the fluid status of the patient because that will affect the differential diagnosis and therefore the management. Any patient who steps into A&E before they come to the medics should have at least a VBG, if not an ABG. Most people will have UNEs done as well, and therefore you can check the sodium. If the sodium is low, then you would need to order a hyponatremia screen, which includes paired urine and serum osmolality, random and 9 AM cortisol, LFT, TFT, and glucose. This will help narrow down the differentials for that cause hyponatremia. Complication of hyponatremia includes osmotic demyelination syndrome. ODS is a neurological condition involving severe damage to the myelin sheath of nerve cells in the pons, which we call central pontine myelinolysis, or in other areas outside of the pons, which is called extrapontine myelinolysis. It occurs as a consequence of a rapid rise in serum tonicity following treatment in individuals with chronic severe hyponatremia who already have made intracellular adaptations to prevailing hypotonicity. So apart from rapid correction of hyponatremia, ODS can also happen with rapid correction of hypokalemia. Most patients with ODS survive, and of those survivors, approximately 1/3 recover completely, 1/3 are disabled but able to live independently, and 1/3 are severely disabled. Permanent disabilities range from minor tremors and ataxia to signs of severe brain damage, such as spastic quadriparesis and lock-in syndrome. Improvements may be seen over the course of first several months after the condition stabilize, but it's still not that well known, and neurologists typically say observe and for 6 months to see if any further improvements, but typically if it's past 6 months they're unlikely to improve further. In terms of management, if the patient has stepped in with a sodium of less than 110 or with a reduced GCS or seizures, then pick up the phone and call ITU, because that should not be managed by medics. It should be at least a level 2 or level 3 care. They will need VBG every 2 hours, and they might need hypertonic saline. But what I've been advised by the registrar is, if you're considering hypertonic saline, then definitely seek advice from endo-reg or ITU. We should not be prescribing hypertonic saline by ourselves as F1. With hyponatremia, you aim an increase of not more than 6 millimoles over 24 hours, because if it goes over that, then they're at higher risk of ODS. In terms of managing hyponatremia, it depends on the fluid status. So hypovolemic hyponatremia could be treated with normal saline, so you can give that slowly over the course of 8 hours or 10 hours. It has lots of differentials, could be due to diuretics, vomiting, diarrhea, infection, malnutrition, which fits in with COVID, or it could be adrenal insufficiency, So with adrenal insufficiency, you would look for other symptoms like low blood pressure, bradycardia, hypoglycemia, hypothermia, history of prolonged steroid use, and if you're suspecting that, discuss with a senior, and you probably will need to give stat dose of hydrocortisone 100 milligrams IV. In terms of euvolemic hyponatremia, the differential diagnosis depends on the osmolality. So if the urine osmolality is less than 100, then it's likely to be primary polydipsia. So in that case, you can fluid restrict them. If the urine osmolality is more than 100, but the plasma osmolality is less than 275, then you need to consider SIADH, and that has a long list of differentials which I won't go through in this lecture. If the plasma osmolality is more than 275, then they could be caused, the hyponatremia can be caused by hyperglycemia, which could be due to HHS or DKA, or if they're using mannitol, or they have high triglyceride or high protein in the blood. Hypervolemic hyponatremia is usually caused by organ failure, so heart failure, kidney failure, or liver failure. These conditions cause fluid overload, and therefore you would treat with fluid restriction. And all these you would aim to increase the sodium of not more than 8 millimoles per 24 hours. So going back to COVID, with COVID patients, you're often bleed to see them either because of a rising news score, or more commonly they are desaturating, have an increased oxygen requirement, or they're having fever, rigors, tachycardic, or having low blood pressure. So most commonly they bleed you to see with a patient with increasing oxygen requirement because they have desaturated. If they desaturate and they are COVID positive, you also need to look for other differentials, because in COVID you have risk of ARDS, your increased risk of PE, increased risk of bacterial co-infection, so bacteremia or CAP or HAP. You can also be fluid overloaded, and a lot of patients with COVID and being on so much oxygen, they'll be very anxious, and that can cause desaturation by doing very shallow and rapid breaths. So when you encounter desaturation, you need to decide whether you can manage this on your own. Does that require senior help, or should you call ITU or put a peri-arrest out? I find this the most difficult thing to gauge when I was starting F1. What I suggest would be, if you're uncomfortable managing the patient, or the patient looks unwell, then you will probably escalate this. I would say if the patient is desaturating and you've sort of done intervention, for example, increasing the oxygen, and the patient has stabilized, then you probably don't need senior help immediately, but you would do all the important investigations such as ABG, chest X-ray, to make sure that the patient has not deteriorated further from previously, and then maybe seek a senior advice to make sure that you've done all the right thing. If you, for example, increase the oxygen to more than 4 liters and the patient is still very short of breath, then at that point I would either bleep the med reg or put out a peri-arrest call, because in that case you probably need more help in managing the patient. In general, when you are encountering a patient who has increasing oxygen requirement, you do the ABG, do a set of bloods, do the chest X-ray, decide whether this is likely PE. If it is, then consider a CTPA. In terms of management, you would obviously increase the oxygen to meet the target saturation. If ABG is showing type 2 respiratory failure, then you need to discuss with the senior, likely at least med-reg, to decide whether the patient should be started on BiPAP. If further desaturation with type 1 respiratory failure, discuss with the senior whether this patient is for CPAP if they're already on maximum oxygen therapy. If not, definitely call ITU if they're for full resuscitation for possible intubation and ventilation. Other things that you can be bleeped for is tachycardia. It's normal to be tachycardic when you're not oxygenating enough, but also it's equally common to see patients being tachycardic because they're feeling very anxious. Usually, if other obs are stable and the BP is not low, they're hemodynamically stable but just tachycardic, you can try and give them a small dose of midazolam or morphine to see if that helps with the anxiety. But if you're thinking about PE, then discuss with the senior whether a CTPA would be appropriate for the patient. When they're having fever and rigors, check if they're already on regular paracetamol. If not, give them paracetamol. Or if their fluid status is allowing, so basically if they're not overloaded, also give IV fluids, because they'll be losing a lot of fluids through sweat, and fluids can also help them cool down. If they're rigoring and having fever despite being on antibiotics, then you will need to do a set of cultures, namely blood culture, sputum culture, and urine culture, to complete the septic screen, because COVID patients can also have bacteremia or co-infection in the urine or other places. When you're bleeped to see a low blood pressure, first thing that you could do is give a bolus of fluid challenge, usually 250 mils, or if they're young and fit with no heart failure, you can try 500 mils. If it's responding, then you have a bit more time to figure out why they're hypotensive. But if they're not responding to, say, 3 boluses up to maybe 1 liter, then start getting help. They might need ITU intervention for inotropes. One thing that's very important for F1 to do is to update the next of kin. It's not the most interesting thing to do, but it's actually really, really helpful, because if the patients have COVID, the next of kins are most likely unable to come in to visit. Therefore, they would really appreciate if you update them about the patient's condition. Alright, so F1 is also very have a very important role in doing discharges. So there's a lot of considerations when discharging COVID positive patients. For example, you need to inform the relatives that they have COVID so that they can you can advise them on isolation if they have been in the same home. If the patient is from a nursing home or from a care home, the homes have different requirements for discharges, because they could be a home who already had a COVID outbreak or a home who does not have COVID patients. So sometimes they would require a number of COVID negative swabs before they're able to go back to the home. It's always a good practice to put down the COVID swab dates and the results of it, so that the GP or the home can refer to the swab dates and decide on follow-ups or whether they need a side room, things like that. Some hospitals do follow-up for this COVID patients, or some of them might need a repeat chest x-ray or repeat UNEs because they had AKI in a few weeks' time. So that has to be documented clearly in the discharge summary and explained to the patient. So that's all for today's lecture. Hope that has been helpful. If you've got any question, drop me an email and I'll do my best to answer all of them. Thank you very much. Have a good day.